Good afternoon. Thank you. Welcome, everyone. I'm Erica Vanderwall, Planning Director for the Office of Mental Health. I'm so happy to be here. I'd like to start with some thank yous. First, I'd like to thank all of you for coming right after a snowstorm. Really appreciate it. And I'd like to thank everyone who's joined the live webcast. We had over 2,000 people registered to join virtually today. So hi, everyone joining from various parts of the state. This is such an important event for us, so it really means a lot to have you all here. I saw Kathy Coons is here, the Director of Community Services for Rensselaer County. So we're here in Rensselaer County at Hudson Valley Community College, and I just want to thank everyone from the college for having us. And a particular shout out to Fran and the team who have been so lovely to work with, and President Michael Brophy for having us, appreciate you. And a shout out to the HVCC Psychology Club, their president, Dee Brown is here. Dee, thank you for being here. And yeah, there we go. The Psychology Club and their professor, Dr. Miller, invited me to meet with them a few weeks ago here on campus. And I did an overview of the mental health system here in New York for them, so it was wonderful to meet with them. So here's our plan for today. As always, we'll begin with a presentation from Commissioner Sullivan and her panelists on agency priorities, new initiatives, and today we're really going to focus on outcomes from the billion-dollar investments from 2023. We have a lot of outcome data to share with you today, and among other things. So we've packed a lot of information into our slide deck as usual, but we'll try to get through everything. And then in the second portion, which really is the most important to all of us, is hearing testimony from attendees. So from individuals here in the room, as well as individuals who have joined virtually, we will hear your feedback. And hearing your feedback is critical to the work that we do at Office of Mental Health, and I'm going to talk a little bit more about that later. Questions that you have, concerns, feedback, anything we want to hear today. I also just wanted to mention about that testimony, what we do with that information each year. We look at themes from the testimony presented and organize that in a report that goes alongside the themes from the county local services plan. So every county, similar to what Kathy Coons does every year, submits a local services plan about local needs and local initiatives. So we incorporate those themes with the themes from today's town hall testimony into a report that's posted on the planning office webpage on the OMH website. So before we begin, I just want to go through a couple of technical instructions for those who have joined us virtually. Within the webcast page for our virtual attendees, if it's not open already, you can open the overview box by clicking on the little overview icon, and there are subtitles in both English and Spanish in that box. We have American Sign Language interpretation on the webcast. And we're recording today's event, so the recording and the slides are going to be posted on our website shortly. And a transcript translated into any language requested can be available by request. And then lastly, for our virtual attendees, the way that you can ask a question, add a comment, submit your testimony is through the question box. If that's not open already, you can click on the question icon at the bottom of the webcast page, type in your comment or question, and send it in. When I'm on my laptop later, I am not multitasking. I will be looking at the comments that are coming in for testimony later. Just wanted to clarify that when I'm on my laptop. Okay, so now I want to introduce all of our panelists, starting with Commissioner Sullivan. So maybe we'll do introductions and
first?
then
Okay.
I'll...
Okay. Hi. Good afternoon, everyone. It's a real pleasure to be here. And again, I just want to echo what Erica said, to thank you all for coming. but also to thank you all for what you do each and every day. Whether you're a provider, an advocate, a recipient of our services, a family member, you're so important to all the work that we do. And I really appreciate, and I know everybody on this panel appreciates everything that you do each and every day. And we also really want to hear from you. So please feel free, whether even later, if you want to talk up now, or if you want to send information to us later, to let us know how we can do things even better. I think in today's presentations, as you hear from all of us, we're going to be talking first about some of what we feel are some of the accomplishments that we've had. And then as we get towards the end, we'll be talking about some of the challenges that we're all facing. But I think it's good sometimes to also pause and take a look at some of what we've all been doing that has been successful as well. So with that, I'll send it down. You want to begin, Ben?
Sure. I'm Ben Rosen. Privileged to be here. I'm the new Executive Deputy Commissioner for OMH, and I will pass it. We'll just pass it down.
Hi, everyone. I'm Janine Perazzo. I'm an Assistant Commissioner for the Office of Hospital Care and Community Transitions. Really good to be here with you.
Good afternoon, everybody. My name is Imari Wilson. I am the Acting Deputy Director of the Office of Diversity and Inclusion at OMH. Thank you all for coming.
Good afternoon, everyone. My name is Liz Breyer. I'm the Chief Advocacy Officer for the Office of Mental Health, and also I oversee the Office of Advocacy and Peer Support Services, and thank you all for coming.
Good afternoon, everyone. My name is Sam Fletcher, and I'm the Director of Workforce Development.
Good afternoon. My name is Sarah Kriakos. I am the Associate Commissioner in the Children and Families Division at OMH.
And we have a few other guests in the front row here, if you all wanted to introduce yourselves.
Hi, Miriam Tepper, Chief Medical Officer.
Oh, I forgot to give them the mic.
Hi, Tracy Wilson, Chief of Staff for the Executive Deputy Commissioner.
Hi, Bob Moon. I'm the Deputy Commissioner over Community Programs and Managed Care Policy. Good to see you all.
Good afternoon. I'm Chris Smith. I'm the Associate Commissioner for Adult Community Care.
Now we can pass.
Okay, so again, this is a list of what we're going to be going through. I won't go through it all because you'll hear it as we go down, but we're going to begin with talking about some of what we have been instituting since that $1 billion investment and where we are in the progress of many of the dollars which came forward. And then we'll be talking about some specialized pieces of the program across all the panelists. And then lastly, I've asked Ben to be the person who's going to talk about some of the challenges that we're facing. So that's coming up a little bit towards the end, but basically is critically important to what we're going to do in the future. So to begin, just to go over again that these are the critical issues that we're interested in, making sure that we have in all the services we have in the Office of Mental Health. So we want our care to be integrated. We want it to be diverse, have equity and inclusion as a part of everything that we do. And we have not scrubbed that from our philosophy or from the work that we do, just to let everyone know that that is there, that that's important, and that is a part of everything we do each and every day. That individuals and people with lived experience are critical to how we design our services and how we staff our services and how we provide them to the clients that we serve. We want our care to be individually focused. We're a big system, and sometimes it can feel more bureaucratic than personal, but we're always striving to make it increasingly personal, and your ability to help us do that is really important. And then we want to always involve community and have community engaged in what we're doing. And we're trying to do that, and that's a part of what we're doing today. So these are the key priorities that we have. To first of all, mental health of all New Yorkers. It's a big task, and certainly we're not there yet, but it's something that we strive for. And prevention as a big priority in that. Traditionally, mental health agencies have not been as involved in prevention as I think they really need to be. And that's something we've been striving to increase, and I'm going to talk a little bit about that as we go forward, because that's where you really get a big bang for your buck if you can prevent individuals from suffering with mental illness. Ensure access to care and treatment when and where you need it. Not have those waiting lists. Make sure the providers are available. ensure a comprehensive continuum of inpatient and community services. And the governor's tremendous investment of that $1 billion has given us the opportunity to really grow that continuum, to invest in it, and that's what I'm going to be talking about, where that money has gone, and what we're beginning to see is the outcomes from all those dollars that were put forward. And building that continuum, a strong continuum that serves everyone from early prevention through episodic mental health treatment, through those with the most serious, complex challenges, that we have that full continuum of care. And then lastly, to ensure that everyone has the ability to live a full and thriving life, and that part of recovery from mental illness, but also the ability to be who you want to be and to fulfill your hopes and dreams, and that's a critical piece. That's what it's all about, ultimately. Okay, so now to go into some of what we've been doing. This is, again, a huge thank you. I've been around in this system for a long time, and I've never seen the investment in mental health that this governor has put forward. So I always just have to say that, because I do think it's just incredible. Over the past 3.5 to 4 years, it's been about $2.5 billion investment in mental health, which is really incredible. Okay. I have to give us and all of you a big plug for this. But Mental Health America did a survey of 17 criteria that they used to look at states and how they were doing in mental health. And when they looked at that criteria and they added up all the scores, New York was ranked first. So it's really kind of cool. I think it speaks to everybody here in this audience, everybody on the tele, or all the work that you do. We did very well with our with things that looked like adolescent depression. We did very well with adult involvement in care. So it's really something I think to be very proud. We should all feel very proud that New York is really leading the way. Not that that doesn't mean there's a tremendous amount still to be done, but this is still, I think, something that everybody should take some pride in. So we're going to talk a bit about prevention, access to care, and complex specialty care services, because these were the three big buckets of that $2.5 billion over the past several years. This is what money has been invested in. So I can't go through everything, but I'm going to give you some of the highlights of what we've invested in and some of the outcomes that we're looking at. So investments in prevention. This is all of it. Two big areas. One is Healthy Steps for Children and Youth. I'm going to show you some of the outcomes for that. This year's budget includes, that's what's on those little red ones, expansion of clubhouses, expansion of teen mental health first aid. We now have thousands of teenagers in sophomore years in high school who have received teen mental health first aid, which is that wonderful program where teens learn how to talk to teens about mental health issues, and a home maternal health initiative, which we're starting this year in terms of collaborative care in OBGYN practices, something which we've done for many years in pediatric practices and in general primary care, but not in OBGYN practices. So that's a really cool expansion. So just to give you some of this kind of infographic, it's a little busy, but this infographic is something that as of January, on all the initiatives that we have, will be appearing on the OMH website. So this is a little bit of a preview of where we're at with the initiatives, where we're at with how we've built them, and then where we are with some of the outcomes that we're beginning to gather. And this is going to be there. We put it this way so it's kind of easy for people to see. So this is, for example, Healthy Steps. So far, we have 132,000 children and families that we're reaching with Healthy Steps. Healthy Steps puts a mental health practitioner in a pediatrician's office, and they do various screenings, and those are the numbers on the screenings. When we fully implement this, it'll cover about 300,000 families across New York State. So it's very exciting, and it's there really to do that kind of primary prevention. They will work with families. You don't need a mental health diagnosis. All you need is an issue that you want to bring to someone's attention, and they do a lot of these screenings. So that's very exciting. It's moving forward. The screenings are yielding results. The next is improvements in school-based clinics. We now have almost 1,300 school-based clinics across New York State, and here's where we're beginning to get some of the outcomes. For example, a 75% decrease in the number of individuals placed, I'm sorry, I jumped. This is not the school-based clinics, this is the general clinics. In the general clinic, a 75% decrease in wait lists. That's really kind of impressive, because if you know, one of our big problems was always wait lists for clinic services. That decrease is due to the expansion of all the clinics, CCBHCs that we've been expanding, the clinic services we've been expanding, some changes basically in the way some of the clinics are operating, insurance reforms, other things enabling more access, but it speaks to access to care, that second big bucket, which was access to care. So here you've got some of the outcomes that we're following to look at to be sure that what we're putting in place is having an impact. So we're decreasing wait lists, and we're increasing the number of clinics who assess patient access to food, housing, and transportation. And why is that important? Remember, we got this big waiver in New York State, the 1115 waiver on the DOH side for social networks. Well, it's important that we connect to those social networks, that we screen and know if people need those supports. And so that's a significant increase in what we're doing throughout our clinic system. One example. The next is examples of investments in suicide prevention. And again, what I talked about with youth mental health first aid, expansion of various kinds of services in the schools, and suicide. The very sad loss of life by suicide in New York State has remained level. In some ways, that means it's not going up, which it is across much of the nation, but it's about level in terms of total numbers. But there are subgroups of individuals who both attempt to take their life, but also have lost their lives by suicide, that are increasing. And one of those, for example, is Black youth, where that number is going up almost exponentially. So there are a number of programs embedded in all this prevention that deal with individuals in certain areas across the state. Another has been Latina adolescents, and we have expanded something called Community Life, which is Community Life, Life is Precious, which is a specialized program for Latina adolescents. Started in New York City, in all the boroughs of New York City, but now we also have it in Amsterdam and Yonkers and Poughkeepsie. So we are expanding, and it's basically a program for young Latina adolescents who have significant depression and thoughts of suicide or suicide attempts, and helps them with a whole host of growth activities after school. It's really not just treatment. It's actually involvement in community, et cetera. It's been very successful, something we're growing in prevention. And then, in addition, this is just talking again about what I mentioned very briefly about maternal mental health. We had a whole work group that did this work, and then we have the Collaborative Care Award, which is coming out on maternal mental health. Now, investments in access to care, a lot of investments in access to care, but a few for this most recent budget have included the expansion of our sustained engagement teams. It's also in our inset teams. It's also some expansion of a pilot program for OMH licensed housing for individuals to be able to stay in residential units. They don't have to leave as we age. And then all these other expansions. The 26 new certified behavioral health centers, all that money's out there. So we now have 39 certified community behavioral health centers. It's the largest number of certified community behavioral health centers in the nation. And basically, they are able to serve over 100,000 people. When they're all up and running, it'll be another 100,000 individuals with those 26 new CCBHCs. So again, that's affected the wait list, that's gotten access. And the CCBHCs provide, remember, really good integrated mental health and substance use care. So that first goal to have good integrated care, the CCBHCs are a prime way of doing that. So the CCBHCs are doing a great job. Significant expansion of our ACT teams, assertive community treatment. With the full expansion, we will have almost 10,000 slots. I can show you some of the, this is CCBHC access to care. This is the expansion. This increased higher rates of follow-up from CCBHCs, engagement higher. In other words, we're following the outcomes to see what's happening in the CCBHCs. The CCBHCs also have a consistent significant decrease in inpatient admissions, both for behavioral health, medical, and substance use. So that shows the kind of integrated care that you get less hospital admissions and less ER visits from certified community behavioral health centers. Again, another big win if we can continue to expand these across the state and get these working well. They have great outcomes. Other set of outcomes is the inset teams. This is the teams that basically are peer-led, peer-staffed teams that work with individuals with high needs, complex needs. These are growing. They are connecting people You can see there, 20% are connected to permanent housing. There are 345 individuals engaged. So there's a lot of work going on. And again, these are individuals who have very complex needs and have not often been able to be, we have not been able to be successful helping them in the current system. And these inset teams are making a huge difference. ACT teams. This is a massive expansion of ACT teams. We will have almost 10,000 adult slots and almost 1,500 youth slots for ACT with the expansion dollars that we had. Again, those numbers show the decrease in inpatient admissions, the decrease in self-harm, decrease in suicide risk, et cetera. So we're monitoring what's happening with all this expansion, clinically what's happening, and making sure that the services that we're putting up are the quality that we want them to be. And again, CPEPs, we've had 31 total CPEPs now, 9 new ones. These were in areas of the state which by and large were not covered before. And they are now, some of them are open up for business, some of them are getting ready to open for business. The good thing about CPEPs is that when you have a CPEP per visit, you have less admissions because you have a whole host of people around who can work with individuals, and you also have better follow-up from CPEPs. So we want to grow the CPEPs because they're better staffed to be able to provide really good emergency work. Just to emphasize, I'm not going to go through this in detail, that a big part of this has also been, insurance reform, which has been critical in making sure that it's not just Medicaid, but that commercial insurers are also paying for the kinds of services that are important for New Yorkers. So I won't go through all these, but these are all happening. We're monitoring them, and hopefully this will have a significant impact. One big one was that basically our clinics have to be paid at the Medicaid rate. Often our clinics were being paid by insurers at below the Medicaid rate if they were commercial insurers. But now they have to pay at least at the Medicaid rate. That makes a big difference for the viability of our clinics. So again, remember the 10-day appointment? Well, that's now something that's real, that basically everyone should be able to get a 10-day appointment if they are insured by an insurer. In New York State, and if you're not, they should be calling CHAMP, the group that will, CHAMP, I forget what the acronym stands for. Anybody? Well, anyway, CHAMP, C-H-A-M-P, it's a number you can call if you don't have access to care or you have a question about your insurance not giving you what you need. You can call CHAMP, and we have a whole host of people who can help you, including lawyers, who can actually begin to make sure that you get the care you need. So again, we're monitoring these insurance changes to make sure that they're real. Now, we're also sending out to the clinics soon a survey to be able to monitor capacity even more closely. I know we're asking, if any of you out there are clinic providers, you may be saying, you know, I don't know if adding more data and giving more data takes time. But the point of getting this data is to be able to show exactly what our capacity is, to keep an eye on those wait lists, and to make sure that we're doing the right thing. So I know it's a little burdensome in some ways, but it gives us better data. We used to do one survey once a year in a one point in time survey. It's not good enough to be able to really understand what's happening in the access to care system across New York State. So we're asking for your help with this, but this will be coming out. We'll be asking for this kind of data starting early next year. So just a few investments in the complex care and specialty services that I just want to highlight. The big one that's coming out soon is going to be the new budget is going to be clubhouses, and that RFP will be out in about a week and a half, 2 weeks for the clubhouses. So we're very excited about that, and also expansion of inset teams and peer bridges will also be coming out soon. The work for the expansion of the behavioral health response to a crisis, those teams, that RFP is out, and we are expecting response soon. That's 6 pilots across the state, and we're very excited about what's going to come with that, and that should be happening. We're getting those responses back by January, and so we can get that started up. So again, much of what was in last year's budget, almost all, is out there or will be out by the end of December. Again, some outcomes. This is just housing. Now, there's going to be some talk about housing later. It's those of you who are in work in supported housing know about the new changes to HUD, which are very serious in many ways across the state. They do not affect OMH housing that much. because we are basically funded almost entirely by state dollars, not by federal dollars. So we have about 51,000 units of housing across New York State, supported housing of one kind or another. Again, that's kind of monumental. There are very few places that have that kind of investment in one of the most basic things that people need, which is a safe place to live. So we're very proud of those 51,000 units. A percentage of those, probably about 1,000, may be affected somewhat with some of the HUD changes, but overall, we are very stable in terms of the New York State OMH funded housing. That's not all housing, but the OMH funded housing. And very proud of continued expansion of this. There's another 6,000 units that are expected to come up within the next 2 years. So again, that continuing growth of supported housing for individuals across the state. Specialty services like Safe Option Supports, we're very happy with the results of these teams across the state. 1,500 individuals have been placed in permanent housing who were formerly across the state, New York City, but also all across upstate, living on the streets, basically living undomiciled, and many of them for months, years, some even for decades, and are now in permanent housing. It's a lot of connecting. It's a very complex issue to work with individuals who have serious mental illness and have been unhoused for a long time, but it can be done with a lot of support and a lot of connections and the right kind of housing. And so these 1,500 individuals are now in permanent housing. It's not just movement to a shelter. It's permanent housing, which is, and if you think about it, probably the number of individuals who are in this category of individuals who are living unsheltered, outdoors on the streets, it's probably in the range of 3,000, maybe a little bit more. So this is a significant dent in that number, between 3,500. There's now close to maybe a third of them have now begun to move into permanent housing, which is really exciting. And just to emphasize that in addition to all the outreach and getting people into housing, and that was outpatient, we do have an inpatient, a specialized inpatient unit that works with these individuals in the state system. And these are the individuals who in some ways are the most challenging. And these individuals, we've had a success rate of almost 63% remaining in permanent housing long-term, which is very, very exciting. Okay, I got to speed up here. The critical time intervention teams are working on connections with people from emergency rooms and inpatient. We don't have a lot of outcomes yet because we're just building these up, but we'll be following it over time, and you can see this infographic grow over time. We now have about 353 individuals engaged, but we're going to have a lot more as those up to almost 3,000 ability once we get all these up and running. Okay. Inpatient care, we have increased state psych beds, and we've also put back up many beds that were closed during the pandemic. And then I'm just going to close with just a quick mention of the crisis system, which is growing across New York State. We have now had, since the 988 number began in 7/22, we have had 1 million calls to 988. That's pretty impressive. And if you remember, 988 is not just a referral. It's not just a referral system. It's also not just for people in major crisis. It's anyone can call for anything. The average time someone spends is about 15 to 20 minutes on a call at 988. So they're doing tremendous work, and supporting all that are mobile crisis teams, crisis stabilization centers, and crisis residences. And then just lastly, as I mentioned earlier, the pilots for the health-based response teams for crisis, that RFP is out, and we are also establishing a technical assistance center, and we are really looking forward over the next year to implementing these pilots, but not just in the pilot areas, also learning so that we can eventually have this kind of health-led response to a crisis across New York State. That's our goal, not just to have it in the pilots, but the pilots will inform us, and the pilots hopefully will include both urban and rural areas. That's what the RFP went out for. So now I'm going to turn it over, and I think I went over time a little bit, so I'm going to turn it over to Sarah to talk about children's services. Sarah.
Thank you, Commissioner. Thank you to all of you who are here and on the live stream for a little bit of time to talk about Children, Youth, and Family Services. As the Commissioner mentioned, Governor Hochul has made youth mental health a huge priority, and we're so pleased to be able to implement some of her vision. I want to talk first about two really important advisory boards we have, the Youth Mental Health Advisory Board, which we run with our colleagues at OASIS, as well as the Family Advisory Board. Commissioner Sullivan mentioned at the beginning how one of the guiding principles of the agency is to follow peer voices, voices of people with lived experience. You can never go wrong when you're listening to young people and families. And so we've had the privilege in partnership with Youth Power and Families Together of New York State to hear from the Youth Mental Health Advisory Board, which is made up of middle and high schoolers. These are the coolest kids, I have to say. We had over 300 students apply the first time. They serve for 2-year terms, and then 150. They come from across the state. They are like busy. They're doing basketball, they're doing regents, and then they get on a bus to come to Albany a couple times a year on a weekend to talk to us about mental health. We have learned so much from them. It's truly been so valuable. They've been able to meet the commissioner, executive deputy commissioner, and one of the things that I want to highlight over the course of the next few minutes is some of the ways in which we really try to put their words into action and be led by them. We also have our Family Advisory Board, and these are caregivers of young people, particularly middle schoolers and high schoolers. And they also have weighed in so many times on what is really helpful and what isn't helpful in the mental health system, and how can we move toward a truly youth-guided, family-centered vision of care. And so in that spirit, today I also want to use the time to lift up a couple of quotes from young people and families as I talk about 4 initiatives quickly that we really designed and put forward in response to feedback that we got from youth and family constituents. So the first that the commissioner mentioned already is Youth and Teen Mental Health First Aid, and we have our partners from Mahaney's here who help us implement this program. This really came out of young people, high schoolers in particular, saying, you know who we go to when we have mental health problems? Each other. Not you extremely old person. We talk to each other, and we want to do better at it. I want to do better when my friend comes to me. And so Teen Mental Health First Aid is relatively new as a curriculum from the National Council. It teaches high schoolers how to talk to each other, how to identify mental health challenges and substance use challenges, and then how to support each other. And then Youth Mental Health First Aid helps adults who work with young people to support them in those. And so from our teen mental health, one of our participants after the training said, quote, "I used what I learned just a few weeks after the training. I noticed a friend wasn't acting like themselves, and I felt comfortable asking if they were okay." So we really know that this is actually changing the experiences for young people, and then as we go through schools, that it's actually changing school culture as people can talk about mental health and substance use in a different way. New York State is very proud to have the largest number of teenagers trained in teen mental health first aid in the country, and we are not going to let anybody catch up. We are going to go faster and faster. So then we have another extremely cool initiative called Youth Safe Spaces. When Governor Hochul in 2023 went around the state on her youth mental health listening tour, one of the things that came out of it is young people saying, we want a space to go where people aren't telling us what to do. We want a space to go where we can choose how we spend our time, and we get to be a part of decision making about what happens in that space. Youth Safe Spaces was informed by hundreds of New Yorkers who gave up their time to join us in focus groups and stakeholder sessions, and especially young people who said to us, this is what it should look like if there was a place in the community where I really felt safe. And so I won't go through all of these, but I want to just highlight some of the foundational principles, which are on the second part of that table: positive youth development, recovery orientation, civic engagement and advocacy, mental health awareness, and social equity and justice, which I think line up very well with the guiding principles that the commissioner talked about. One of the things that I want to talk about on the next slide is the way that we used feedback, particularly from young people, to put together the initial vision of these youth safe spaces, of which we're so proud to have awarded 4, and then shortly we'll have a procurement for another 4 to come out because it was funded again in the next cycle. Young people are very good at keeping you accountable. So after they give all the feedback, they'll say, what did you do with all of that feedback? So on this slide, I want to highlight some of the things that they said and then what we did. So young people said, let's discuss teachers educating and not scaring, talk about risks. And so out of that, we built in workshops for adult allies that can be delivered from youth safe spaces. Young people said, we want staff that look like us. They know what we've been through and they can just relate. So we required the staffing plan to match up with what young people said that they wanted. I won't go through all of them, but I do love the fourth one that says, I would feel safe in a place where I could take a nap, eat my favorite snacks, and my mom didn't have to worry about picking me up, which really just speaks so much to meeting the basic needs that contribute to mental health and wellness. And so because of that, in our program design, we built in requirements around public transportation, hours of access for young people, and that part of the budget had to be devoted to food and transportation so that young people who were there didn't have to worry about meals or snacks. I want to spend a little bit of time also talking about 2 programs that are more line up with complex care specialty services that the commissioner mentioned. And these really tie, I think, to both feedback from young people and families that when they are in crisis, they want services to come to them in their home so they can stay in their home and their community. And they want individualized services, as the commissioner mentioned. So I'd like to highlight our youth assertive community treatment. So New York State is one of the pioneering states in the country to roll out a nearly statewide assertive community treatment team that's specialized for young people and families. These are for young people who would otherwise be in a psychiatric hospital unit away from their families for days or weeks. And so really high risk young people who are able to stay home because a team can wrap around them. And we do see decreases for them in their social challenges, in their suicide risks, and in their danger to others or physical risks. And so I want to highlight, we had a young person who wrote a letter to every member of her team after she was discharged. And she said, "You saw my strengths and you believed deeply in me. You made me feel comfortable expressing my emotions, and I felt understood by you." Last one that I want to highlight is our home-based crisis intervention team. This is a very nimble program that we have in almost every single county, except 2 counties at this point in New York State. A huge amount of gratitude for the governor's investment in increasing access to this service. This is a program where each interventionist carries only 1 or 2 families on their caseload, which means that they can be very flexible and very available to families for any of the needs they have for about 4 or 6 weeks. And I love this quote from this family member. And I'll end on this note because it's a great one. I think Ellen was amazing. She listened. She not only called out my daughter's BS, but mine too, which is never easy. She helped us to solidify that the family as a whole needed work. We still used the skills she taught us. I felt like she connected to each of us differently. We felt seen by her, every one of us. When she was here, she was always present, and we felt like a priority.
Again, thank you all for being here, and it's a pleasure to speak to you all. I'm going to talk about some of our training and workforce initiatives. I'm going to begin with training. As most of you probably know, training helps with staff satisfaction as well as recruitment and retainment, so it's a very important part of workforce. I'm happy to say that OMH funds over 24 training platforms and technical assistance centers. We have been working hard over the last year and a half to create a web page on our website that lists those centers as well as every training. So if you look at the slide, you can see that purple button that says training database. That database is a great tool for both staff and our supervisors in OMH licensed, designated, and funded provider agencies. They could pull up every single training that's listed at those training TA and training websites, as well as filter them by topic area. So if a supervisor thought that the staff needed more training in trauma-informed care, they could filter by that and assign those trainings to their staff member. This is a great tool that we update quarterly, and I just got an email today that this will be updated this week for the latest update. Keeping on that same vein of training, part of the investments that OMH received went towards specialized training for hospital staff. So I'm going to talk about two of those initiatives. One is our trust training. Trust training approaches are trauma-informed, they're empathetic, they focus on recovery and resiliency and person-centered practices. To date, and this just started this year, we have trained over 180 participants in train the trainer sessions. So that means those participants can go back to their hospitals and other congregate care settings and train their staff. So it's kind of a ripple effect with those train the trainer sessions. In addition, in October, we started our first Project Echo with 11 hospitals participating. Project Echo is a really unique training opportunity. It's virtual training that creates a learning collaborative where people use real case examples and they're able to problem solve together and think through these complex systems issues together and really think of those solutions together. One of the most popular workforce initiatives that we have is the Community Mental Health Loan Repayment Program. This program offers loan repayment for licensed practitioners that work in one of our licensed, funded, or designated provider agencies. The practitioner does a 3-year service commitment, and for psychiatrists, they can earn up to $120,000 in loan repayment, and then for all our other licensed professionals, they can earn up to $30,000 in loan repayment. We have done 7 rounds of this program, and we have made awards to over 1,400 individuals at over 200 agencies. Round 8 is going to be released in the next few weeks. So make sure you keep an eye on our procurement website, which is linked on these slides, and look for round 8 to come out. We've been working hard to create partnerships with universities and colleges across the state. I'm going to highlight 2 of those partnerships. The first is a partnership we have with the SUNY system, where we created a internship program for community college students. This program piloted last January in 3 community colleges, the Finger Lakes Community College, SUNY Niagara, and Monroe Community College. We had 50 students who were in this initial pilot. It went so well, we had some students that were hired before the internship even finished. And we just found out this week that this program is growing. We're going to add between 2 to 5 colleges for the next round, which will begin in January. So once those contracts are signed, we'll let you know which community colleges those are. And then also the SUNY CUNY Pathway Scholarship Program. The goal of this program is to diversify the workforce. So like what you were talking about, the kids want. They said, I want people who look like me to be in the room. This ties to that. We also want that for students and for adults who are seeking services. We want people to feel comfortable when they go into the room. So this program, We have almost 200 students participating in 31 different schools throughout the SUNY CUNY system. The students receive up to $10,000 a year, and they can repeat that for 3 years, and then they'll do a 2-year service commitment afterwards, working in our system. OMH also has several different fellowships and residency programs. Again, I'm just going to highlight 2 of those. The first is our Psychiatric Physician Assistant Fellowship Program. We worked with H&H Hospital in New York City in 2024 to develop this program. And I'm happy to say that it launched in September. We have our first round of fellows at H&H. The fellows will receive additional training, so they'll be doing psychiatry rotations, they receive additional didactic training, and they have mentors. The whole goal of the fellowship is that at the end of the fellowship, they'll be prepared to take what's called a Certificate of Additional Qualifications, or a CAQ, and this certificate will allow the PAs to work anywhere in the public mental health system because we'll know they've received that extra training in psychiatry. I also want to highlight the nurse residency program. This program is for graduate level nurses and then also nurses who are entering psychiatry field. This program provides the nurses with training, education, mentors. It really hones up their skills in the psychiatric field. And we've had 184 graduates from this program. This is really exciting. On my first day at the job 2 years ago, I was told we're going to make a credential for the paraprofessionals. And we have been working on it, believe me. We've been putting a lot of time into this. So we're creating the credentialed mental health support specialist. We're working with a vendor to do this work. And right now we're at a stage to where we've already created some core competencies and different levels. And now we're going to go in and work with actual support staff who do these roles to get those tasks, the knowledge, skills, and abilities that they'll need at each level. Then we're going to be calling on you, the public, to validate what we find. So look for emails, probably from Olivia on our team. Next year, she'll be sending them out and inviting you to stakeholder sessions to be able to validate what we find. This is really going to be great for our paraprofessionals. They're going to have mandatory training, they're going to have an identity, and then this will create a ladder where they can work up. We're also working on initiating a Medicaid code so that they will be able to work in the MOTORS clinics. Now, they can work in, now we can have support staff in the clinics, but we don't have a way to pay them currently. So that's what we're looking at, is how do we get Medicaid reimbursement to pay them to work there? And then my final slide I'm really excited about. Internally, we call this the game changer. So we are working with a vendor right now to create a workforce website. I'm looking at the person running it in the back of the room, Amy. And we're working with the vendor to be able to find out from you. So we're going to be calling on you guys again to help give us information about this website, about what you want on there and what would be helpful to you. But I can tell you 3 things that we know will be on there. One, we're going to have a career roadmap that has all the positions in the public mental health system so that people will be able to see what they would want to do and find out how to get there. Like, what education, what licensure do I need? We're also going to have all the settings. And we're going to have videos with those settings talking about what they do and what a day in the life of working there looks like. This will be a great tool for our people who are hiring that they'll be able to send to prospective employees to see if they're interested in that setting. And if they're not, have them look at the other settings. Let's find a perfect place for each person and they can do what they want to do. And then one of the most important things, and the final thing I'll talk about, is the job search function. So someone will be able to go in there and click Psychology Wayne County, and every place that's hiring psychologists or who do hire psychologists in Wayne County will pop up. So we'll be able to match job seekers with places that hire that position. So we're looking very forward to that. And now I'm going to pass it to Liz.
Thank you, Sam. So I'm going to give some brief updates on peer services. The theme that I'm hearing from the panel so far is that representation matters, which is one of the reasons why peer support services are such an essential part of our system and so needed. And as the commissioner had highlighted in relation to our INSET teams, our intensive and sustained engagement teams, this is a primary example of the beauty and the benefit of how peer support can help folks. There are lots of different ways to engage people, and trust can take a really long time to build, but about a second to lose. And one of the reasons why peer support can be so beneficial and why that intensive support can be so helpful right out the gate with someone very early on in their recovery journey is because there's that shared lived experience paradigm. They have some frame of reference of what it may be that you are experiencing, and they've navigated systems, they understand how to work through those systems, and they can really just sit and hold space with you and just demonstrate that hope, that there is hope and possibility, not just that recovery may happen, but that recovery will happen. And so that's why we're so committed to INSET teams and continuing them. We have an RFP out currently, so I won't be speaking about that one, but we do have 4 INSET teams around the state right now, including one that's specifically focused on forensics. Between January of 2024 and September of 2025, 778 people engaged, which is phenomenal for a new program. That's really excellent. And 20% connected to permanent housing, as the commissioner mentioned. Housing can be really difficult for people to achieve, and being able to connect with someone who understands what that experience is like, really, there's no comparison to having that conversation with someone who's navigated that and who has lived on the street and who understands the challenges around that. And we're also looking at milestones that matter. Yes, reducing hospitalizations, that's what we all focus on, of how do we keep people out of the hospital. But there are also other things in life that matter and other barriers that can get in the way for folks. And participants are averaging about 1.2 milestones per month. The average person can usually achieve 1 goal every couple of months, maybe 2, so this is pretty much right on target. And it's not limited just to the very medical model-oriented goals, although that's not off the table if that's what someone wants, but we're looking at things like wellness goals, reconnecting with family members, with parents, with siblings, engaging in substance use treatment if that's wanted, celebrating sobriety milestones, completing a job orientation, completing parole and probation. Really anything that the person is wanting to work on, the INSET team will work on that with them. But the key piece is it's that intensive support very early on, and it's being offered to you, and someone is sitting with you and holding space with you who has, again, some frame of reference of what you've gone through. We also are committed to keeping the infrastructure of peer support services in place, so we're expanding on our peer bridger services around the state. They really do demonstrate that efficacy of supporting wellness and recovery. And also, you need some help when you're leaving someplace, when you're leaving a hospital and you're trying to figure out what does life in the community now look like after that experience, whether it was a brief stay or for some folks, unfortunately, much, much longer. And it can be really challenging, and there are so many barriers that can get in the way, including what does life look like now that I'm discharged and back out into the community, which is one of the reasons why bridger services are so essential. People need help navigating that. Not just about connecting to other services, although that's important, but what does that conversation look like? What does it mean to suddenly be out on the outside and sort of, figuring out again, what are my next steps? So we have an RFP that's out currently to expand bridger services in Article 28 hospitals. It's not as many as we'd hoped for, but it's still something, and it's good. So we have 3, let me make sure I'm giving you the right. 3 awarded hospitals will receive $300,000 for 5 years, and that will be for about 3 bridgers per hospital. So that's considerable, and we're really excited about that. The applications are due for the current RFP on the 15th of January. It was posted not that long ago. We're also, we have re-procured our Academy of Peer Services. This is really the foundation of the certification process for peer specialists. This has been around for a while now. We've reinvested, reissued this out again. There's a lot of gold in these modules, including for anybody here in the audience who may be supervising peer specialists and not know enough about the actual discipline and the practice of providing peer support. We have specialty tracks set up for that, for people specifically who are supervising, who are not familiar with the work, to be able to catch yourself up and offer that in-discipline supervision. But the Academy of Peer Services offers those modules and the ability to take those modules that allow you to become certified. We have technical development that's offered there, instructional design, project management, new course development, learner support. That RFP was issued on the 20th, and the applications will be due back on January 15th. So we're excited to keep that going. And then finally, we are also reprocuring and reinvesting in the New York Peer Specialist Independent Practice Association. This is a really phenomenal initiative. This is 12 peer-run organizations from around the state who have different levels of expertise that have joined together to combine that expertise and be able to offer that to the state of New York. The IPA will work with partner organizations around identified shared goals, stay current on the latest trends that are happening with the peer support industry, maintaining that strength-based approach to relationships between organizations, and really the overall goal of the IPA, which is collaboration and professional development for the New York peer specialist workforce. So we're excited to continue the funding for that as well. And that's all I have.
That's me.
Back to you.
Thank you, Liz. So I'll be quick, but this is my favorite thing to talk about. So community engagement, events like today where we get to go out, OMH gets out on the road, speak with individuals, families, individuals with lived and living experience, family members, advocates, peers, providers from across the system and county leadership to get feedback about how to make the system better. And Sarah mentioned this as well with feedback we get from youth and families. We really use this information that we collected. So I'm just going to briefly go through a couple of the examples of community engagement that's going on right now. And this information that we collect gets used in creating new initiatives. So many of the initiatives you're hearing about today were created based on feedback from these various sessions that I'll go through. The feedback also influences regulation decision policy making. So community engagement, in the past year alone, so this is under Liz's leadership in collaboration with the planning office, our field offices, our county leads, and others throughout the agency, we went back out on the road. Over the past year, we've done 23 community engagement sessions. These are in-person sessions. We have small groups with individuals and families to ask them how to make the system better. Some of the themes that have come up through those, and there's multiple different themes that we're looking at, there's a need for more awareness of these services that we have available and how to access them. I think that's one of the most common themes that we've been hearing. A need for transportation has been a major theme in some of these areas, and a need for cross-system work amongst the state agencies to work together. Hospital and community connections is near and dear to my heart. We've done 10 action planning meetings throughout the state where we're taking a hospital catchment area and gathering the providers from across the system together at the same table. These are leaders from hospitals, clinics, care management, advocacy, peer bridgers, housing, to talk about improving communications with one another when someone's in crisis and the hospital is involved. The regional forums, I think people in this room participated and people on the call participated. We pulled these together quickly. In November, we did 6 regional forums. 5 were virtual. 1 was in person in Albany, where we were talking about the changes from federal actions that have been going on for this year, in particular, the Congressional Reconciliation Bill that Ben's going to talk about. We discussed in these small group forums how those changes are going to impact our mental health system. And some of those themes that we talked to people were about leveraging the existing resources we have in our state to help people with Medicaid recertification, to help people with finding employment and keeping employment, to help build messaging and information materials so we make sure we get the word out to individuals to know who is affected and how that they can get support. So I learned so much in those forums, and thank you to everyone who participated. We're using that information every day for planning. And then lastly, I just wanted to make sure everyone knows, so New York State has a suicide prevention strategy that is coming out very soon. So that's going to be posted momentarily. And I mention it in this section because the Suicide Prevention Center of New York, under Jay Carruthers' leadership and his team, they met with 24 subject matter experts and 86 individuals with suicide-centered lived experience to get input about that strategy that really helps shape the goals that you'll see when that comes out. And now I'll pass it over to Janine Perazzo. I could talk to you about that all day, but.
Thank you. So I'm going to talk today about the progress we've been making on transition and access to care, particularly for individuals who have more complex needs. So one exciting thing is in November, we had our first, what we hope will be the first of many forums. We convened peers, providers, researchers to really identify opportunities and have discussions around how do we support both recovery and safety. And really around a very small subset of individuals with serious mental illness who are at risk for aggressive behavior or more specialized and integrated care. And so I stress that it's a small cohort, but often clinicians and providers spend a lot of time talking about that small cohort because of the specialized and integrated approach that is needed for them. So it was a really great day, and I look forward to actually more convenings and discussions and really being able to share the information that we gleaned and came up with together. And then something I'm very excited about is we started, it's about almost 18 months ago now, a new office at OMH called the Office of Hospital Care and Community Transitions. And we've really been focused on partnering with the hospitals that have licensed inpatient mental health program, as well as community-based programs, particularly around serving and working with those individuals with complex needs. And our goal as an office is really to strengthen admission, treatment, and discharge planning practices with the thinking that then we'll see kind of changes in outcomes. And the ways in which we've been doing that is, one, we've been really working hard at updating regulations and then working on guidance to support those regulations. We've been rolling out some of the trainings that Sam talked about, the trust training and the ECHO training. We've been working closely with our field offices and our licensing department and the hospitals to bring beds that were lost during COVID back online, and then also the addition of new beds in some communities. And then the thing that I actually find really exciting is we've created regional teams. So I'm actually going to go to the next slide because I think it kind of shows the work that we've been doing. So these regional teams are actually teams that are based in Western New York, Central New York, Hudson River, Long Island, and New York City. And they're actually on the ground going into the hospitals and working with the hospitals around the updated guidance that I mentioned and the regulations. So they're really providing that technical assistance and support on the ground. And we've been staffing up this year, and you could see from the graph that like our visits are getting more each month as we're almost actually fully staffed. And so this year we visited 70% of the hospitals in the state, establishing a relationship, learning from them what the challenges are, and then kind of deciding together what are things we can support them on, with a lot of emphasis on that transition piece that Liz mentioned, because it really is such a tenuous time, and the system, as we know, is so complex. And then this is just a timeline. In the interest of time, I'm not going to go through it, but you can see over the past couple of years the work that we've been doing on updating statute, guidelines, and regulations for hospitals. So we've really been emphasizing it, working closely with them. I think one thing I'll just highlight is last year we updated the regulations for our inpatient units, our CPEPs, and then we worked closely with DOH to update the regulations for the emergency departments. We will have joint guidance coming out with DOH for the providers to actually support them during this transition. And then here's a timeline of the technical assistant training that we've been doing for the hospitals over the past year. ECHO and Trust were highlighted, but we've really been trying to get out there and train and work with them, and really hearing from the providers what are the things that they really need support around, and seeing what we can do to put those trainings in place. And then, Erica, you just mentioned hospital and community connections, where we've been actually going into the communities localized and working together to come up with solutions, again, focusing on that transition piece, individuals going into the hospital and then individuals coming out of the hospital. So with that, I'm going to turn it over.
Good afternoon, everybody. Again, my name is Amari Wilson, and I also wanted to mention that I'm here as the Deputy Director of the Office of Diversity and Inclusion in place of our Chief Diversity Officer, Talia Santiago Bonds, who couldn't be here today. And I just wanted to give a brief overview of kind of what we do within our office for the agency before talking about another area that I'm just excited that we've been able to do. So some of the work that our office does is a lot of policy change, supporting and coordinating and implementing policies aimed at reducing disparities in access, quality, and treatment outcomes for OMH operated, licensed, and funded programs. So we also commit a lot of our work towards training and technical assistance, conducting comprehensive trainings, and providing technical assistance on the importance of infusing cultural and linguistic competence through all agency policies and clinical practices. It's a huge part of really creating a culturally competent or culturally responsive mental health system. Other work that our office is committed to is language access. Similar to today, having translated and interpretive services, not just at our community events, but also within our state-operated facilities where people receiving care can do so in the languages that are natural to them. And we work collaboratively on workforce diversity. We oversee OMH's efforts to plan for and implement activities to recruit and retain and create diverse workforce to really maintain that inclusive environment across all OMH offices and facilities, ensuring the compliance with State Executive Order 31. One thing that I said I was going to be really brief, so I'm going to be really brief in the interest of time. One thing that I'm very excited that we were able to do as an agency just 2 weeks ago was have a health equity summit, which addressed mental health inequities in rural communities specifically. So this was hosted last month on the 17th and 18th. We had over 160 registered individuals. We were only planning for 150. So it was great that to hear how it was landing in local newspapers and how the word just got across to different rural areas. To have people really gather together, leaders, practitioners, people with lived experience who shared and explored the social drivers and social economic factors that really shape access to care across New York State and specific rural areas. So the conversations really emphasize the importance of building connections and our shared commitment to advancing mental health equity across the state. On this slide, you also see some of the panels that we had. These are the specific topic areas we had included, and it was a lot of stuff into two days, and there's so many more conversations that we're excited to have in the future.
Okay, thank you. So I've been given the task of talking about the elephant in the room, the federal actions that we are going to be fighting every step of the way. So, as others have covered, the HR 1 passed in July. It's going to have some significant changes on the state's mental health system, as well as the state's healthcare system in general, as well as the state's basically any state system that's supporting people. So changes to Medicaid eligibility, cuts the essential plan, and the risks that those pose that will stress the system and create uncompensated care and barriers to people seeking services. Non-citizen populations have been targeted in this, and in changes to the health insurance in HR 1. But I think the governor and every agency under the governor has had a very clear direction of maintaining access to care wherever we can, and maintaining and expanding the services that we're continuing our expansion throughout all of this. So in the interest of time, I'll keep going here. So this is a very dense slide, but the Medicaid changes will be seen in December and January, really targeted at the expansion population, those who have, based on a modified adjusted gross income of 138% of the federal poverty level. There are new work requirements of 80 hours per month, which includes working, community service, a work program, educational program, or some combination of these activities. We'll be working to figure out ways that we can expand opportunities for people in our system to access those community service, work program, and employment. And then, as well as figuring out what the people who are exempt from that requirement are, and making sure that our providers in our system have the tools to assist the people they're serving, navigate this more complicated process. Eligibility determination of Medicaid every 6 months. Currently, it's a 1-year interval. Going to 6 months is going to be damaging. It's already difficult for providers to maintain that eligibility, help their clients maintain eligibility. And so we're also going to be looking for tools and solutions to assist, whether it be data systems, whether it be work processes, to assist our folks getting that eligibility, because that's step one. The changes to the essential plan. HR 1 eliminated $7.5 billion, which is impacting services for 1.7 million New Yorkers. The New York State of Health has submitted a formal phase-out plan to reactivate the basic health program, which predated the Affordable Care Act coverage. If this happens, the plan is for next summer, July 1st, for that transition to occur. Folks will be given notice, and we'll make sure that that we are messaging the same. Lawfully present non-citizens won't be eligible for that essential plan, and effective October next year, Medicaid eligibility will no longer be available for qualified alien populations, with some exceptions. Obviously, there's some nuance there, given there are court cases that kind of define the coverage that's required for some populations. Getting into SNAP, this is something I think everyone is aware of, something that we dealt with during the federal shutdown. But there's also kind of longer-term impacts under HR 1, again, to the work requirements. Able-bodied adults without dependents can only receive SNAP benefits for 3 months in a 3-year period if they don't meet those work requirements. Obviously, that's very scary, because we have a lot of folks in our system and in New York generally who are reliant upon SNAP benefits. So there'll be additional screenings and recertifications. We'll be working very closely with OTD, Office of Temporary Disability Assistance, and local social service districts, as well as our directors of community service, to make sure individuals have access to that employment and or other opportunities, and that no one loses benefits because they didn't understand the new rules or didn't know where to turn to. So this would be a big education campaign necessary. Okay, and I know we have a bunch of housing folks in the audience today, so I think this is on the top of their minds and also on the top of ours. HUD is providing billions of dollars to support housing, and as we mentioned before, New York State leads the nation in support of housing. And there are new restrictions that are part of the Notice of Funding opportunity that will impact funds supporting permanent housing. Just to set the stage, 35% of permanent housing beds are funded via the continuum of care system. Under the NOFO restrictions, there'll be a cap on the amount of COC funds to be utilized for permanent housing at 30%. Currently, 90% of COC funds go to permanent housing, so there's going to be damage done here again. And the changes obviously impact the housing first model of providing homeless services. COCs are expected to prioritize projects that have treatment requirements. Our AG, Tish James, along with a coalition of other attorney generals, have filed a lawsuit. And we are going to be doing more work on this as well, engaging throughout the state to find out ways that we can hear the details of how they are dealing with the changes within their COCs and helping to plan together. And we know that the things that are outside of the OMH system will have impacts on the OMH system, given the administrative funds that the providers rely upon to get their business done, and that threatens the viability of our providers. So we have to be very attentive to that. So I think as we said before, and as Amari underlined for us, we are not going backwards as New York State. We will still be emphasizing diversity, equity, inclusion, and belonging across all of our programs. We will continue to support LGBTQIA populations throughout the state, including the individuals seeking gender-affirming interventions. We will continue to provide mental health services to non-citizen and undocumented immigrant populations. And we really need to hear from you of ways that we can do better. I think we've been making some significant progress over the last number of years, and we know that there's so much more work is needed here, and we can't afford to go backwards. So we shared, we sent out a few communications recently about resources for not only for the individuals who are receiving services in the public mental health system and where they can go for help, including federal action reporting forms so you can make that complaint to the Attorney General's office, but also hotlines where they can go. But this is really, there is a additional threat of federal presence in New York State, and that's something we're very attuned to. And we've issued guidance to our providers on what to do to prepare for that. In terms of sensitive locations and where, what is required to when a federal officer may show up at a mental health program. So we need to make sure that we are all prepared and that people, not only our providers are prepared, but the people they serve are prepared and educated about what to do in those situations so that we don't, so that we can best fight this off. And then, in addition to all the stuff that Erica mentioned on our community engagements, what I think has been, kind of unprecedented for the Office of Mental Health, and I think very helpful for us to understand what the needs are across the state and hearing from communities. We've also heard from advocates and provider associations, and this is just a list of all of those whom we've met with, really based around how can we mitigate the federal impacts, how can we streamline our regulations, how can we, what things can we change to maximize revenue, knowing that the impacts of Medicaid cuts, uncompensated care increases, and all sorts of other things are going to really be hitting home for the providers and for the people they serve if access is limited. So these are a few things we are taking, and just I think we have a great number of other items in the works. But really, we heard and we're responding around regulatory relief, streamlining project approval and licensing recertification processes, finding ways to expand that telehealth service, which is particularly important for people who don't feel comfortable coming to an in-person service, given potential of federal presence, in collaboration with our state agency partners to really address some of the needs of providers who have to go through many different processes in order to do business. Figuring out ways to maximize revenue, figuring out better billing practices, providing support for billing so that providers are able to maximize their billing, knowing that, again, impacts are coming. And then around service design, about group psychotherapy, intensive outpatient programs, as well as kind of looking at all of those contracts that we have now with technical assistance centers, and figuring out how we can really help aim all of those efforts in a concerted way to address what we know is coming. And really figuring out, getting more and better data so that we can forecast the impacts and better be equipped to respond to them. So that, anyways, they did leave the most entertaining part for me, and I'm sorry I have to be the bearer of bad news, but I will turn it over to Commissioner Sullivan.
Okay, so really, thanks. I think that's it. Oh, okay. A few more quick things, and then we really want to have time to hear from all of you. So again, the network adequacy regulations and financial services, et cetera, all the changes we've made with insurance are also there to basically also protect the provider system and the access to care. And those I think will help during this time when we are dealing with what's could be up to a $14 billion hit to Medicaid. So what we have to do is come up with ways that we can maximize, as Ben said, maximize our revenue within what we're doing, but also maybe streamline some of our regulations. That one particular one about having to have someone after hours on site for telehealth, so we're going to get rid of that, so that basically I think that'll make a big difference for some of the clinics that had suggested that to us. So there's things we're changing. And then with the health insurance, we're basically looking at making sure that commercial payers pay their fair share of what has to be, of services that we provide, especially since we might be getting a hit to some of the Medicaid reimbursement. Again, just to keep in mind that, again, the bills and the money going through the commercial system are very important. So please, if you're not getting reimbursed, if you're a provider, the way you should be from commercial insurers, we should know. And there's that CHAMP number that I mentioned earlier. So you can just contact us and let us know if in any way some of these insurance reforms are not really working for you. 988, again, I think get the word out as much as you can about 988. You know, every time I talk about 988, there's still people who come up to me afterwards and go that they hadn't heard about 988. So while we think everybody maybe knows about this, I don't think everybody does. So keep the word out, especially in these difficult times. It's going to be increasingly important that people know they can call 988 for anything. They can find out whatever information 988 will connect them to what they need. So please keep pushing the word out there about 988. And then lastly, we do have some work that we're doing, and you can go to our website on wellness. There's a lot of information out there about wellness, and I think it's important for all of us to also take care of ourselves and each other during this time. You know, you probably put the oxygen mask on the yourself first before you put it on your kid next to you. So you have to take care of yourself first, guys. And I think that we're thinking about wellness and wellness for the stress that our provider system is facing as well as the general stress out there among all our clients who are facing uncertainties about things like SNAP benefits and things like how you can have certain wellness activities that can be helpful. So I think what we will do is stop there and open it up for questions.
Yes.
Erica?
Yes.
Okay.
Thank you so much, Commissioner, to all the panelists, and we'll get right into our testimony, starting with individuals in the room. Thank you so much, everyone, for signing up. And I'm going to start with Pierre Cote. Please come up and use the mic here in the front. Want to make sure we have that sound turned on. And thank you to everyone virtually. I'm seeing your comments and questions come in. Really appreciate it.
One, two, hold on. Good afternoon, Commissioner Ann Sullivan, distinguished member of OMH, and fellow attendees. Shout out to all my friends and fans at Fountain House who are watching us right now. Shout out to the education unit and Molly. My name is Pierre Cote. I am a New York certified peer specialist, a member of Fountain House, and the creator of Drellis.ai, a free trauma-informed AI companion designed for men facing addiction and emotional isolation. I need to say that I have lived experience with mental health and addictions, and I've been sober for more than close to 28 years. And thank you. So I am not normal. I have lived experience with mental health. So this is really important for me to be here to advocate. At last year Town Hall, I state that no one in a mental health crisis should have to face the weight alone. Today, I'm here to report that while the public sector waits, the world has moved on. I am here to ask OMH to catch up. We know the statistic. Men account for nearly 80% of all suicide deaths in the United States. Over 6 million men are affected by depression annually, yet less than half receive treatment. But here's the statistic that keeps me up at night. We are currently witnessing the rise of an unregulated shadow mental health system. While we debate policy, the private sector has captured the desperate. Over 80 million people use, as an example, ChatGPT weekly. More terrifying, 1.2 million of them represent conversations indicating suicidal intent every single week. This is happening right now, without ethical oversight, without ethical guardrails, and without the protection only public health leadership like you, Commissioner, can provide. Millions of young Americans are turning to generative AI for help because the wait for us and them is too long. This is not science fiction, this is true reality. New York is uniquely positioned to reclaim this space. We are grateful that the governor has allocated over, if I'm not wrong, $1 billion to strengthen our system, including substantial funding in fiscal years 25-26 budget for hundreds of new inpatient psychiatrist beds. But we must ask, how do we ensure those beds are available for those who truly need acute care? The answer is artificial intelligence integration. AI is not a replacement for caregiver, is the upstream triage system we are missing. It is the tool that redirect men from the emergency room by engaging from them before the crisis peaks. By investing in AI, you are safeguarding the integrity and capacity of the physical infrastructure you are building. At Fountain House, not talking in the name of Fountain House, but as a member of Fountain House, and this text was vetted by the executive director, but anyhow, at Fountain House, we aren't just talking about this, we are building the governance model you need. So we secure $750,000 grant from the KPMG Foundation to establish responsible AI adoption and governance. We are piloting Heyday, a voice-first AI that helps members document their own progress note, reducing administrative burdens so staff can focus on people, not paperwork. So it's a pilot. And we have launched an AI working group, and will soon establish an AI review board based on an internal review board and research to evaluate projects from the Bronx to Harlem to Hollywood. Commissioner, this time last year, I asked for awareness. Today, I'm asking for infrastructure. My request is specific. OMH must move beyond strategic conversations and establish a digital health and AI task force. I know you have meetings, but try to include clinical partners and different partners. Don't start from scratch. Partner with us at Fountain House. Use the government's framework we are building at Fountain House as your pilot model. Let us help you set the national standard for ethical, clinical sound, publicly accountable AI. My tool, which is available right now online, Drellis.ai, is already without any mental health supervision or approval or institution. It's online available, supporting men in over 100 countries, including the United States, India, Greece, South Korea, Brazil, China, Australia, Germany, Mexico, and Russia. All because those men had nowhere to run. It's available right now. We have exported this innovation worldwide. Now it's time to bring that same emergency back home to New York State. Let us be the state that protect our residents by shaping this technology rather than being shaped by it. Thank you very much.
Thank you, and there's a lot of very, very wise statements there, and I think we are in the process of working throughout the state. Obviously, AI affects many, many things. There's positives, there's negatives, there's a lot of controversy, there's a lot to be looked at, there's research that is there, there's research that isn't there. So it's a complex issue, but you're absolutely right, it's something we are taking on and we need to take on. So thank you, and we will be in touch, as we have been. So thank you very much. But it is a critical issue going forward. It's going to be shaping a lot of what society does. And so we need to be on top of it. So we are looking at it, just so you know. So we'll keep you updated as to where we get. Thank you.
Thank you so much, Pierre. Next is Glenn Lieben. And while you're coming down, I'm going to read a couple from the chat. So please come on down, Glenn. So we had Ryan Gallagher from CHAMP is on, and he reminded us that the acronym is Community Health Access to Addiction and Mental Health Care Project. I definitely feel like I should have known that. Thank you, Ryan. And that is a mailbox that we're using to monitor complaints about access regarding, in particular, insurance companies. So thank you, Glenn. And I also forgot to mention the 3-minute limit, just so we have enough time for everyone. I'm sorry, Glenn.
That's all right. I'll talk fast.
You're the best. Thanks.
Right. Hi, everyone. My name is, first of all, thank you for holding this forum. My name is Glenn Lieben. I'm the CEO of the Mental Health Association of New York State, been CEO for over 20 years. Our organization is comprised of 25 affiliates in 52 counties throughout New York State. We largely provide community-based mental health services, but we're also very involved in advocacy, education, and training as well. And I'm also the chair of the Behavioral Health Advisory Council, and I'm also, the most important thing I am is I'm a family member of someone with a psychiatric disability. Over the years, I've had the opportunity to present on several issues that are germane to community mental health. During this time, I've presented, the prevailing theme has been, of course, our shared advocacy around workforce and provider funding. We have always very much appreciated the leadership of you, Commissioner Sullivan, Governor Hochul, in advocating for our workforce. I should have brought different glasses. Over the last 4 years, we've received over a 10% cost of living increase. While it did not keep up with inflation, it is the most by any governor in recent New York State history, and is greatly appreciated. There has also been, as you reiterated today, there's been a historic investment in mental health, and there's no coincidence that New York was rated the top mental health state by our national organization, Mental Health America, as you pointed out. That is the good news, but as we all said, that's just sort of the starting ground. There continues to be great unmet need in our community. Deaths of despair, homelessness, incarceration, overcrowded emergency rooms reflect the continued overwhelming needs that must be met. Recent changes in the federal government has been talked about, also have grave consequences for our sector. In the backdrop, we continue to fight harder than ever for an increased funding for our workforce. This year, we're advocating for a 2.7% targeted inflationary increase, which is in line with the Consumer Price Index. Workforce funding increase is not a panacea, but is the lever for real change. All the innovative ideas that you talked about today are just like, it's like the Beatles' greatest hits. It just keeps coming and coming and coming. You know, dramatic expansion of housing, ACT teams, CTI, Children's Mental Health Crisis Services, prevention services, suicide prevention, SOS, and of course, our favorite, youth and teen mental health first aid. Now, we need staff in place to run these programs. Clinicians, direct care workers, peers, families, and paraprofessionals. Without the promise of these great programs, we will not come to fruition without the staff to run them. I make the analogy as a sports guy, it's like having a great baseball structure, a great baseball team, a great baseball farm system, terrific ownership, top-notch hitting instructors, great scouts, an amazing sabermetrics department, and a terrific manager, but without any players on the field. We need to have players on the field to succeed. I will not get into detail about our vacancy and turnover rate. They are catastrophic. And all of our members can tell you stories that are abysmal about that. And we're sitting here, and again, I've talked about this probably ad nauseum for over a decade, but we're still in a situation where, and I'm sure we'll hear from other people as well, that we remain in a workforce crisis, that we can't hire the people to run these innovative programs, and it's very frustrating, I'm sure, to you as it is to all of us. But where do we go where we can get this funding? Our mental health system funding has been driven by the state-operated psychiatric hospitals for many years. Do the math. In the 1950s, we had 95,000 people in psychiatric hospitals, and today we have 2,700. We have closed only a small amount of hospitals during the last 75 years. So what's happened to those, you know, basically, we're gone from 95,000 to 2,700. While we have need for funding in our community, empty wards and hospitals are costing millions of dollars to run. We continue to pay workers, food, oil, gas, technology, and much more for an incredibly small percentage of people. Yet we have thousands of people in our correctional facilities with a mental health diagnosis, huge waiting lists to get services, and overcrowded emergency rooms. We need to immediately create a psychiatric hospital redevelopment commission, similar to the governor's successful prison redevelopment commission. We need more alternative use ideas, such as the housing program at Creedmoor, which the governor touted a few weeks ago, and we support that incredibly. We need to retain, most importantly, we need to retain savings from any hospital closures to reinvest in community mental health and for desperately needed funding for our workforce and provider agencies. And finally, I don't know where I am in terms of time, but I do want to say one more thing. Since we're on the campus of Hudson Valley Community College, I really want to thank Governor Hochul and Commissioner Sullivan for their leadership in advocating for school-based initiatives and the innovative credentialed mental health support system specialist. Utilizing skills of recent college graduates, community college graduates, and high school graduates into our future mental health workforce for career ladders and other initiatives is incredibly far-reaching, and we're very hopeful for the future in that. So thank you very much.
Yeah, thank you, Glenn, very much. And I think that certainly I've read what you've talked about the hospitals. I just want to say a couple of things. First of all, yes, we do have land that is connected to some of our state hospitals. And basically that land, which is being redeveloped, like at Creedmoor, it's great. That land is now going to go up for housing shortages, and that's something that's being negotiated on almost all our campuses. Some campuses are a little more profitable for developers than others, but that's something that we are working at across the state. But when it comes to state hospitals, I think it's important to consider something. We do not have a lot of vacant units. What most of our state hospitals are now have been converted, if they are not inpatient, into providing outpatient services and space for community-based programs. So our hospital campuses are a little bit different than they were in the past, where they were just seeing inpatients, and they've been developed into things that in some communities, even though it seems a little bit odd maybe to have so many, are the mainstay of the psychiatric services in those communities. largely outpatient, not inpatient. So I think when you think about the state hospital system, you have to think about it nowadays a little bit differently than we've thought about it in the past. We do a lot of inpatient. We also do a lot of outpatient. We have a lot of residential on our campuses. We have a lot of step-down units on our campuses. Our campuses are providing a big continuum of care for individuals with a serious mental illness that is really pretty important. So I think it's not exactly what was there before. That doesn't mean that there can't be some things that can be improved, but I think it's important to look at the totality of what happens on those psychiatric campuses. That isn't to say that there isn't a lot of land that could be used wisely, like the land at Creedmoor. So I just wanted to kind of say that, and we can discuss that more. But your point about the workforce is so well taken. This is a national crisis in terms of the mental health and substance use workforce across the nation. We're not the only state facing this. It, by and large, has historically been under-resourced. And I think our governor has done more to do that, but you're playing a catch-up here of decades of misfinancing of the mental health system in terms of the workforce. I mean, I think what we're trying to do with a lot of support is get people involved in the workforce to continue to make the working conditions interesting and better so people will come. We've talked about the loan repayments, some financial incentives we can do. But you're right, we're still in a workforce crisis, and we have to work together to try to come up with as many solutions as possible. So thank you so much for bringing that up, and also just recognizing just how great the workforce that we do have is. And I can't thank them enough for what they do each and every day. So thanks, guys.
Thank you. Next is Laura Isabel. And a couple comments from online. There's a couple people from the Family Advisory Board on that did a shout out, and they love being part of the board, so wanted to tell you that, Sarah. Got a few comments about that. We had someone ask where to find the RFPs. So I just put into Google OMH procurement website, and it pops up as the first thing. So that's how I find our RFP page. Please go ahead, sorry.
Good afternoon, and thank you, Commissioner Sullivan and all of OMH for convening today's town hall. My name is Laura Isabel. I am the Director of Policy at the Association for Community Living, or ACL, where we represent the nonprofit providers that make up the mental health housing system. Today, I would like to speak to the urgent need of a 2.7 targeted inflationary increase, or otherwise known as a COLA, and why this is essential for stabilizing the behavioral health system, as well as the housing continuum and the operational foundation required to run residential programs. Community mental health housing providers are experiencing ongoing strain in managing their day-to-day functions. With staff vacancies at around 30% and annual turnover above 50%, it makes sense why our members are struggling. The complexity of the population served today is markedly different from the population served 4 decades ago, and not all housing models have been modernized or brought into alignment with these current needs. Legacy housing programs are eroding. SROs are 90 million below ESHI rates, but serving the same group of vulnerable individuals. And although the 2025 rates were just released, scattered site programs really need about a $100 million investment. But we're at a time in which most developments at the federal level are unsettling. We recognize there will be trade-offs around funding. This is why the 2.7 matters so much, because life is expensive. Linens, food, cleaning supplies, kitchen supplies, appliances, utilities, all of the basic household items you and I buy regularly. When inflation goes up but funding stays the same, this is a cut that falls primarily on services and staff because fixed costs like rent need to be covered first. Housing is where recovery takes hold, but even the best housing model cannot function without the staff and infrastructure in place and regularly adjusted for. The 2.7 keeps the continuum intact. It's the bare minimum our members need, and that's why we're asking your support and urging the governor to include that in next year's executive budget. So thank you for your time and your leadership.
Thank you. Thank you. Thank you.
Thank you, Laura. Harvey Rosenthal. And while you're coming down, I'm going to read another comment. So someone put into the chat, School districts want to partner more effectively with OMH to expand access to behavioral health services. Given the persistent barriers families face, such as transportation, childcare, and inflexible work schedules, what steps is OMH considering to modernize regulations, like flexibility we had during COVID, so school-based behavioral health clinics can offer telehealth services to students and families who cannot reliably access in-person appointments? Thank you for that testimony. Harvey?
Hello there. Thank you, all of you, for all the work you do, and congratulations for being the #1 in the country. We know how hard you work and how much you do, and the governor's behind this and the innovation you show, but I wouldn't be doing my job if I wasn't saying what else is needed. We are, the national threat that you mentioned is so strong. I've never seen anything like it. The coercion, I don't know if you know, in Utah, they just put up a detention camp to house, 130 people off the streets and coerced to go to Utah and stay in a camp out there. Harm reduction is under attack. Housing First is under attack, making it harder for people to get the care, food and, SNAP and Section 8. And SAMHSA has been taken down in a major way. But New York State is really being a fighter here, and really appreciate it. The governor's position on SNAP when this first happened was really heartening. The Alliance's key focus, as you know, is freedom, is choice, is liberty. And I love the word sort of continuum that you use. A voluntary continuum, if we fill the whole thing in, is critical to that. I'm going to switch to something right now. I lived in Albany County. I worked there for years. When we're talking about forced treatment in Albany County, or any of these counties, but this is a local issue. And when we're looking at forced treatment, what do you have in Albany County that should be there? Do you have an inset team? You don't. Do you have a crisis stabilization center? You don't. Do you have a clubhouse? You don't. Do you have a lot of the building blocks in the continuum? So it's hard, if you're not going to put them up, to say, well, we had no choice but to coerce them. These are people we like to call them. When I started in the field, it was the low functioning. Then it was the non-compliant. Now it's the hard to serve. It's us who have the difficulty. Let's not label them, oh, they're too hard. That's the business we're in. That's why we do this job. So coercion is not the answer. It drives people away. It doesn't really bring people to us. Engagement is critical. Inset, fabulous. Thank you so much for all the work you folks are doing and how you've expanded, far beyond anything I had thought when we began the idea. The SOS teams, fabulous on the engagement front. We're glad on the Diaz Law teams. That's another engagement early upstream, not the police per se, but peers and EMTs, so critical. Need more of that. Great start. We're worried we need more than the first year funding, though. If it's a one and done, we're in a lot of trouble there. Crisis stabilization, we've talked about it, authorized 24 programs. 12 of them are peer or recovery-based. Fabulous. But I think only 6 are up. And I know you work hard at it. Actually, I'll tell you, my son-in-law is a realtor. He's working on one of them now. I know how hard it is with the siting and the neighborhood and all that, as he tells me.
Keep trying.
But we still, 3 years of...
We're going to do it, though, Howard.
If they're there, then less coercion if people have a place to go.
No, you're absolutely right.
Those, however, are only 24-hour facilities, 23. We have peer crisis respite programs. We need more of them. They go from 8 days to 28 days. There's only a few of those. Inexpensive, people can stay. We need, along the continuum, people to walk along you when you're in recovery, if you've been hospitalized. That's a peer bridger. We've been running peer bridger services. We're the first one in the country ever because of you. And we've run it, since 1993. And it's great. And we have maybe 5 or 6 teams, I'm aware of in the state hospitals. And now you're putting up community teams, which is fabulous. But the work that it takes in changing the culture of the facility in which you put the peer program is critical. Otherwise, peers become case managers and not coaches, and that's not what they're meant to be. You talk about that 16.5. We talked about it a lot, about the money to go to the counties, back to the counties. I know, Commissioner, you're determined to not see one order that's offered that that isn't necessary in your way. And I know you have the staff out there and working with the counties. But again, it's critical to change their culture and to line up that continuum, because even raising expectations but not having that continuum, you're going to wind up with more, forced treatment. People need a place to live, so more housing first is really critical here. People need a place to go, and clubhouses. We started out as a clubhouse association. There were 30 clubs when I started, up and down the Hudson and the Mohawk and North Grand Southern Tier. There's so few. Thank God the governor went down there. You've been around there, and you're bringing the backup. That's so critical. And I thank you for that a great deal. We talk a lot about food, shelter, and clothing and transportation, and that's part of that waiver. That's so critical that we get more people assessed into that program. We don't have a lot of time, so I don't know how we can work together. We're putting on forums with the SENs in various areas, but the clock is late, and the feds are not likely to renew it. So we want to, get people the help that they can before the money's gone. And the other thing is, if people don't have food, shelter, and clothing, they're more apt to look like those people that need to be hospitalized because they don't have food, shelter, and clothing. So it's really important that hospitals are not places to give out food, shelter, and clothing, as you know. So to admit people there involuntarily. DEI is so critical, but a terrible thing is under attack. It's obscenity. People think, I think on the other team, it's all about affirmative action. Just giving jobs to people of color who don't deserve it. Outrageous. But the work we do, and you do, really, to change the system so that people are not as they are now, disproportionately in solitary jails, prisons, homelessness, suicidal. Can't do it enough. Thank you for really staying strong on that. I would say self-determination. We talk about psychiatric advance directives. We're working together on that, but if the ERs don't have them visible and use them, they're not worth a lot. So anything you can do on that will be important. Self-directed care, I know we're working on that. Almost done. The last two things is the money. We have 2 piggy banks in this state that have plenty of money to help this out. We have more hospitals. We're number 1 in the country in hospitals. We may be number 1 in a lot of other areas. Number 1 on expensive, large hospitals. And yes, you've changed what's on the grounds, but they're still very expensive. And that money could be plowed into so much more and better there. I'm just riffing here, but you got a hospital in Elmira and one in Binghamton. They're about an hour apart. There's a handful of people in both. There's got to be a better way. Even if it was putting your 90-day sort of bed programs where people could get more intensive help, but not in a state hospital at that expense and that length of time. The final thing is managed care. A number of us are pushing to really carve us out of managed care and give back the money that we need. It's being wasted in insurance companies and all of the what it takes to get that. That's money for the people. If we could get the hospital dollars, the managed care money, then you'll have the money for the COLA that we so desperately need. Thank you.
Thank you, Harvey. Kathy Coons.
Good afternoon, and Commissioner Sullivan, welcome to Rensselaer County. I serve as the Commissioner of Mental Health here in Rensselaer County, and I thank you for the opportunity to speak today. The great challenge before us is to creatively develop solutions to services which are being downsized or lost due to changes to federal funding or lack of workforce, while simultaneously experiencing an increase in acute mental illness in adults and emotional disturbance in youth. In the 45-plus years of my career as a social worker, never before have I seen the level of disturbance in the community as I do today. The local government unit, my office, fields numerous calls each week for assistance needed in managing behaviors in the community. Never before has there been such a need for strong collaborations with law enforcement to work together for the safety of individuals and the community. Never before has it been so challenging to meet medical necessity for psychiatric inpatient admission. Never before has there been so many workforce vacancies. Never before have rental costs been so high. Never before has the acuity of mental illness been so high in the county correctional facility. For 13 years, I have served as commissioner in Rensselaer County. The local services plan has consistently ranked housing as a top priority. Sadly, the need has increased year after year. The greatest need is to expand the housing continuum at both ends of the spectrum. The highest, most supportive level of community residents, and the lowest, least restrictive, low-barrier housing of Housing First. Over recent years, referrals to the community from the state psychiatric centers request CR level of care. The county has data to support the need for CR development. However, there is no ability via New York State to permit this to happen. The lack of CR capacity reduces the ability to discharge from the psychiatric centers, resulting in longer lengths of stay. The discharge rate from the CRs does not meet the admission capacity need. Recent changes in federal housing funding is now jeopardizing housing for at least 150 households in Rensselaer County, some of which include adults with mental illness and children with emotional disturbance, and nearly all of whom have high trauma indexes. I know I state the obvious. Housing is a basic need which is essential for a healthy life. One potential solution to the current challenge with federal housing funding is for New York State to review all outstanding ESHI housing grants, which have been approved but not yet developed. Determine the barriers to development and plan with the awardees to alter the proposal to avoid the present barriers and develop housing in a more rapid timetable, such as how very often single site-based housing is not possible due to community resistance, and scattered site rental properties may be easier to accomplish. Another priority is for expansion of outpatient treatment opportunities. One type of treatment which has become extinct in our community is day treatment. The PROS model, while very effective for some people, is not a day treatment program. Day treatment is a step above clinic and a step below inpatient, and can provide many more hours of community-based support than does a PROS program. In these times of reduced inpatient length of stays and restrictions related to inpatient medical necessity criteria, day treatment is the next best level of care. This would allow for daytime care and offer healthy activities in a supportive milieu. Hopefully, this would also contribute to productive time for individuals and result in less criminal activity, which lead to violations or misdemeanor charges. An opportunity for day treatment programming would make the difference in one's ability to successfully reside in a supported apartment versus a CR. Another goal is focused on increasing peer supports and activities. In addition to including peers in the clinical workforce, peers can operate a drop-in center model of support. So many of those we serve have no meaningful sense of community or friendships. This setting offers a healthy space for recreation and community for folks who are challenged in building healthy relationships and build the strongest component of resilience we know of. As we know, the establishment of meaningful, healthy friendships is a strong protective factor which promotes resilience and wellness. As outpatient holders are the backbone of the continuum of care, I encourage OMH to eliminate the time requirement for the ability to be reimbursed for complex care management services. The current time restrictions required for billing thwarts the ability for clinicians to participate in care planning meetings, especially for those who are disengaged from care. I implore you to lift this restriction as care planning and coordination is essential in this ever-changing environment we are navigating. We are all challenged with quelling our fears and anxieties, and that is just one of the things we all have in common with those we serve. This is a time for us to get back to basics and focus on what supports ourselves, our workforce, and those we serve in building our resilience, which increases everyone's health. Thank you.
Thank you, Kathy. And I know we're at time, Commissioner. Is it okay if we do three?
Sure,
We have
sure.
3 more people in the audience who've
Sure.
signed up to give testimony, so apologies for going over. So next we have John Gunther. John Gunther. And if you could keep your comments to 3 minutes. I'm bad at cutting people off, but I'll try. Thank you, John.
Absolutely. And as a first-timer to this town hall, I took the 3-minute
Thank you.
Thank you all. My name is John Gunther. I work with Vibrant Emotional Health on the 988 side of business. And for the past 7 years, I've been working initially with the New York City, what is now NYC 988, originally NYC Well, and LifeNet before that, in helping to work with the resource directory that we've had for New York City. Obviously, a very resource-rich environment, and I sort of cut my teeth on that. And even prior to that, was kind of talking about this with Commissioner Coons earlier, kind of really learned about the resource landscape of New York City by being an ICM worker from 2000, from the very beginning of AOT, up until about 2017, when we had gone through all the different changes of blended case management and the introduction of the health homes and all that. So nonetheless, coming up to the present, what we've really tried to do, and I think we've done this for a couple of decades now with New York City, is really have a very comprehensible resource directory for the benefit of the entire population, not just help seekers that are just in crisis. And Commissioner, thank you for your 2 PSAs earlier about 988. It's not just for crisis, it's really for anybody in need. So to that end, not only do we list all the numerous OMH services and all their associated acronyms, of course, but plenty of grassroots and community-based services around housing and peer support and crisis respite centers and psychosocial clubhouses and all that. 2 years ago, I got the position to start a new resource directory up here in the capital region, and have tried to bring as much of that template as possible, and had a lot of discoveries along the way, and some surprises to me, a very rural environment compared to New York City. A lot of different trends that we've seen also with how the community is engaging with 988. So, for example, we've done a pretty good job of sort of, even with only 300 resources to date, kind of emulating that structure that we've had for New York City. But we're really noticing a very disproportionate emphasis on telehealth. We added a lot of telehealth resources into the region, but we've seen that month to month we track the utilization, and out of the top 20 resources that we give out, 50% or more are either a telehealth clinic or some kind of virtual support service, not an in-person service. Now, why that could be? It could be, again, the rural nature of this environment. It could be a help seeker preference, and very much possibly the workforce issues that we've been talking about here. And to kind of go along with that, an observation that I make with those that reach out wanting to be a clinical service in 988, it just keeps on going up and up. They're virtual clinics. And they're almost always staffed by what appear to be, I don't mean to be ageist, but young people that are very new to the system, and they're not going into direct brick and mortar level of services. And then I hear, in New York City about 3 years ago during COVID, we had a big push to get CCBHCs up and running. And one of the big attractions about them was crisis walk-in services, having their own kind of mobile outreach within their catchment areas and all that. But very quickly, we heard that they would contact us. We have to put up a temporary message. We can't provide that service right now. We're short-staffed, or we don't have an LCSW that can do the crisis triage for people that walk in, so they would postpone those levels of services. So now we've introduced 2 CCBHCs, or at least updated family counseling centers program, which became a CCBHC in the last year, and a CASIA center, and look forward to being more. But at least from one of them, they just reopened their intake now. They've been closed for a couple of months. So it's hard not to see what this loop is here of, young people coming into the field with their MHC degrees or, MSW degrees are not going into that level of direct engagement, with help seekers. And I know from my own experience as a case manager, how vital that level of engagement was. In really learning the system of care, we had to follow our clients all around the city as an ICM, right? If I worked out of Brooklyn and someone got community residents way up in the north of Bronx or far eastern Queens or something, we kept those clients. That was what engagement meant. And we've heard engagement come up time and time again. And I'm really excited to hear about these services that you did introduce today, the INSET program and the youth initiatives and all that. So, but I guess what I've learned about making a testimonial is that we're supposed to sort of appeal for something here. And I don't know if there's a way to engage this emerging telehealth phenomena in a way like some of the training, loan repayment kinds of things that you talked about. Can we get people to do the in-person brick and mortar type level of service and make that be appealing to them before they just jump right into the virtual only clinics? And while they're great and they've really helped us in many ways here, I keep on hearing from clinicians, and providers that we can't do this service now, we can't do that, we're short-staffed, what have you. So anyway, thank you very much for being here. Thank you.
Thank you, John. Okay. Next, we have Amy LaFountain. Were you able to stay, Amy? There you are. Hi. Thank you, Amy.
Hello. So I'm Amy LaFountain. I'm the Executive Director of Joseph's House and Shelter. So we're a homeless services agency, and we provide outreach services, shelter-based services, and permanent supportive housing. And our permanent supportive housing is HUD funded with braided OMH funds. And we prioritize participants with a SPMI due to that braided funding. And as we've discussed today, right, the changes at the federal level. And permanent supportive housing is under attack. And I guess what I'm sharing is a cautionary tale that we will see more homelessness. We will see more trauma in our families, youth, and adult populations. And while there's already an overwhelming need, and you've already invested, we have to invest more in mental health services and housing. And I wish we had more time to plan. There will not be enough services to capture what I see as a new homelessness crisis. And we have to be prepared to support these folks in resiliency strategies and working through the trauma of becoming homeless or becoming homeless again after having been in housing for 20 years. And we need to support people in ensuring that they know it's not their fault. And we need a plan because there is going to be a new mental health influx when HUD changes go into effect next year. And we need, to the person who spoke prior, we need a workforce who is willing to be boots on the ground. And we need better relationships with the local hospitals who provide emergency mental health services, as there will be an influx of need. And obviously, we need more housing. And I'm also very excited about my addition to what I had planned to say is the mental health support specialists. So what Joseph's House needs is a way to have those staff figure out a way to have them part of our agency. So thank you.
Thank you, Amy. In 2 minutes. That was impressive. Thank you. Okay, and Jackie, can you close us out? Jackie Negri, please. Thank you, everybody. And thank you to everybody who joined virtually. We are reading all of your comments that you're entering, and they will be included in the testimony report. And questions that people are submitting online, I will share with the commissioner and all of the panelists. Thank you, Jackie.
Okay, great. Thanks. Good afternoon, Commissioner, team. I am speaking today on behalf of 11 statewide organizations representing New York's adult children families. They are the Alliance for Rights and Recovery, the Association for Community Living, the Coalition of Medication Assisted Treatment Providers, Advocates of New York, Families Together in New York State, In Unity Alliance, Mahaney's, NAMI, New York State Care Management Coalition, New York State Coalition for Children's Behavioral Health, New York State Council for Community Behavioral Health, and the Supporting Housing Network. Between all of them, our membership collectively serves 1,012 providers offering over 7,202 programs under the Office of Mental Health and under OASIS. As advocates for mental health and substance use disorder-related needs and service providers who support the adults, children, families across our state, we are deeply concerned about draconian federal policies that are or may need to be implemented because of the H.R. 1. As you make tough, you hear my voice is low, that's because I got off that children's conference the past 3 days. I'm listening to myself. As you continue to make tough decisions and any fiscal actions in preparation for the SFY 27 budget, we urge you to prioritize funding requests to preserve and maintain access to mental health services and supports. We know it's trying times, and we ask that you, Commissioner, submit a request to Governor Hochul, as we all have, and asking that our agencies receive the 2.7% target inflationary increase, which is based on the July 2025 CPIU. We need to maintain our services and supports. These are critical times. We are the CPIU is based on actual cost increases. Not only did I hear many of my colleagues speak today on the workforce, but we're also talking about operational cost as well, which continue to increase for our agencies. So for their sustainability, we need to increase at minimal by the TII at 2.7%. The services are life-saving, instrumental to supporting the health, stability, and well-being of our families and communities across New York. And as you two mentioned, it's been years of chronic underfunding, so we're really trying to play catch-up by not receiving the full and the past COLA over the years. We're behind both the public and the private sector, so we see our workforce leaving for both as opposed to being able to maintain them ourselves. Glenn had mentioned earlier some of what our percentages were as far as vacancy rates, et cetera. I have those for you. We did a survey last year. It was a sampling of 43% of the total workforce community, both OASIS and OMH. And the behavioral health sector continues to near experience statewide average of 20 to 30% vacancy rate and a 25% annual turnover rate depending on providers. So those numbers are alarming. And clearly it's not just here in New York, but here in New York, we are behind the efforts because we haven't received those COLAs in the past. We're also seeing providers across the state continue to see increased need without question, mounting wait lists without question, and very limited access to care. So meaningful investments need to be included in the executive's budget to address these significant treatment gaps, the disparities, the ongoing inflationary increases, as I mentioned earlier. This is at minimum what providers need, and I'm going off a little bit here because I know when you talked earlier about the loans, et cetera, now we're looking at the feds saying RNs, these aren't professions, et cetera, so every time we blink, something else is getting thrown at us that it becomes more and more difficult for us to maintain and sustain a qualified, which is our most valuable workforce. Protecting and investing in mental health is essential to public health, economic stability, human dignity. We, again, stand ready to collaborate with all of you. We just ask that at minimum we start with this 2.7% at the TII so that we can continue to sustain our workforce, sustain our operations, and be able to support the many innovative programs you've put forth for children and adults across the state. Thank you.
Thank you, Jackie. A couple of people asked if we're going to have the slides. There's a lot of information in there. We're going to post them to our website very soon. Commissioner, any final words?
No, just to thank you all. Thank you for some really great comments, great suggestions. Thank you for being here, and a huge thank you for what you do each and every day. So thank you.
Thank you.